Hello everyone, Assalamu alaikum and a very good morning from Pakistan. I'm Dr. Farooq Rathore working as a consultant in rehabilitation medicine. And today I'm going to present a literature review on whether telerehabilitation is effective or not. There are three main learning objectives of this presentation. First of all, I'm going to define and explain what is telerehabilitation and what are the different modes and mechanism of delivery of telerehabilitation in different conditions. Then I'm going to present a brief overview of the literature search I have done in order to demonstrate that whether this thing is effective and in which condition it has been used effectively. In the end, I'm going to discuss some of the advantages and challenges of integrating and using telerehabilitation services, and I'm also going to discuss that what is the future of telerehabilitation and what it means for physician in rehabilitation medicine. Telerehabilitation has been defined in different ways, and one of the simplest definitions is that it is the delivery of rehabilitation services over telecommunication networks and the internet. Now, these services could vary in different forms. The simplest could be a simple consultation, just like the consultation that you and me make in our own clinics. So, the patient walks in and he consults the doctor. The doctor takes a detailed history, performs examination, evaluates, and assesses the patient on the first visit. So, this can be remotely done during telerehabilitation, or it could be a follow-up visit for monitoring of certain disease or outcome, or it could be meant for prevention of certain preventable complication. For example, preventing pressure ulcers in spinal cord injury, or maybe positioning in orthopedic trauma, or maybe preventing contracture formation in a patient who is bedbound because of some neurological injury. So all these things can also be done via telerehabilitation during prevention, or it could entail supervision of a exercise session. So this exercise session can be done one by one, in which there is a telerehabilitation rehabilitation professional, maybe a physical therapist or occupational therapist at one end, who is supervising the exercise that is being done live on the screen, and he or she is going to correct the patient. Or it could be done in a group setting as well, in which many patients come together in a hall or in a specific room and they perform these exercises and exercise sessions, and the rehabilitation professional is sitting on the other end via telerehabilitation and supervising these exercise sessions. Or it could entail simple patient education and giving them an insight into their disease and maybe discussing the long-term follow-up plan. So all these services can be provided remotely via telerehabilitation. The modes of delivery can vary, and the simplest is basically a simple phone call. So you call up your rehabilitation physician or professional, and you can get consultation and advice on telephone. But because of the advent of internet and technology in communication, many applications have been made available free of cost to everyone. And now you can do video call and video conferences using this telerehabilitation model. And it actually adds an added layer of connection between the rehabilitation professional and the patient, who can talk to each other, who can see each other, and to a limited extent, the rehabilitation professional can also perform a little bit of examination online. And these video calls can be done by different means. It could be a simple WhatsApp call, a Zoom call, a Google Meet call, or maybe Skype call, or maybe a call on Microsoft Teams. So there are many options available free of cost. In addition, now many medical institutions and commercial organizations have actually created many medical consultation application and software, in which the patient logs in and the rehabilitation professional also logs in, and they can get connected to each other via a video call through a particular server. And then they can get consultation, they can actually ask questions, and in the end, the rehabilitation professional can upload the prescription as well. So there are many medical consultation applications available almost in most of the countries of the world, including developing world. And these are available mostly internationally, and any person in any part of the world can get hold of the rehabilitation professional in that particular country if he or she is registered on that particular platform. Now, the simplest of this telerehabilitation consultation is a one-to-one patient and rehabilitation professional consultation, just like a clinic. So the patient walks in, or the patient gets connected to you online through a video call, and you are sitting at one end, and the patient and maybe the attendants are sitting on the other end. They are listening to you, you're examining the patient, you're asking the patient question, and then you discuss this thing with him or her, and then you give them a prescription one to one. But this can also be done in another different form, in which the local rehab or medical center offers this telerehabilitation program, and the patient have to visit that local rehabilitation or medical center, and then they are connected to a rehabilitation professional based in another city. And I'll quickly give you two examples because this model was successfully implemented both in Pakistan and Nepal, basically during the earthquake. So in 2005, when the Pakistan earthquake came, so there were a lot many patients with traumatic spinal cord injury. After the initial management and rehabilitation, they were sent back home to Kashmir. Now, Kashmir is a very mountainous, hilly areas, and at least during that time, 18 years back, there was very poor infrastructure of road network. So these patients with spinal cord injury could not come back to the main hospital again and again for consultation and for follow-up. And they were patients who were at high risk of developing pressure ulcer, urinary tract infections, and other things. So what happened that, one organization actually made up a mobile team. That mobile team, went to those hilly areas in a mobile van, and that mobile van was fitted with telecommunication network, which was connected with a satellite back in 2005. So this telecommunication van used to go to that hilly area where most of the patient with traumatic spinal cord injury were living in their houses. And they would then collect all these patients one by one, and the patient would come to the van there where they would be remotely managed, remotely given a prescription, and their pressure ulcer were monitored by a rehabilitation physician who was sitting in the main city. Sorry. And the similar model was also implemented in probably 2015 in Nepal earthquake. So when Nepal earthquake came in again, Nepal had only one dedicated spinal cord injury rehabilitation center located in Kathmandu, Nepal, SIRC, Spinal Cord Injury Rehabilitation Center. And my colleague Dr. Raju Dhakal, who was and who still is the director of that rehabilitation center, so they did not have capacity to manage so many patients with spinal cord injury. So he got connected to people based in other countries, Europe, America, Canada, Bangladesh, and even Pakistan, and where he used to get consultation from these experts using online video consultation tools and video conferencing softwares. So while Raju was sitting in Nepal, he was getting help from rehabilitation medicine professionals all around the globe, which was only possible through the use of technology and telerehabilitation. So this is also a model that has been successfully implemented while delivering telerehabilitation. Now coming to the evidence, that what is the evidence behind the use and integrating telerehabilitation in different conditions. So I quickly ran a search on Medline using the word simple telerehabilitation, and I was able to find around 2100 articles on this topic. And the important thing to understand is that most of these articles, around 1460 articles, have been published in the last 5 years, which means that there has been a lot of interest in integrating telerehabilitation services and sort of like creating evidence on use of telerehabilitation services in different conditions in different parts of the world. Unfortunately, so far, most of the evidence that comes in favor of telerehabilitation is from developed world, where they have a very good communication infrastructure, network, and internet penetration and high bandwidth. So what we need is that we need to sort of create more evidence from developed part of the world as well. Apart from that, there are two very important resources that I would like to recommend. One is a book that just came out last year. It is edited by my colleague Markeli Alexandra. So this is an excellent book on telerehabilitation. And apart from that, the Physical Medicine and Rehabilitation Clinics of North America. So in May 21, under the leadership of Professor David from USA, they brought out this special issue in which they discussed the use of telerehabilitation in many conditions. And if you summarize all this literature search, you would be able to see that telerehabilitation has been successfully at least used or implemented or integrated in the management of many conditions across different spectrums. So this would include probably neurological conditions like stroke, traumatic and non-traumatic brain injuries, multiple sclerosis, spinal cord injuries, pediatric disabilities like cerebral palsy and spinal dysraphism, and management of neurogenic bladder and bowel dysfunction. This can all be done remotely via telerehabilitation. It has also been used in the management of many painful musculoskeletal disorders and in patients with burns who are undergoing rehabilitation and who want a follow-up. It has been used in the management of chronic pain because we know that a chronic pain management is a multidisciplinary holistic approach. It is not only the use of medication or physical therapy. There are other components as well, and many of these components can be safely delivered by using telerehabilitation. It has been used successfully in patient with amputation. Now, patient with amputation require a lifelong follow-up and care. And many times, at least in Pakistan and many developing countries, not all of them are able to visit the hospital again and again. So if there is a very small issue which can be managed via telerehabilitation consultation with a rehabilitation professional online in a virtual environment, probably it's worth exploring. It has Telerehabilitation has also been used in the management of cancer rehabilitation, because cancer patients have different issues which could include maybe weakness, different kind of polyneuropathies, painful syndromes, and many cancer patients are not in a condition in which they can actually come to the hospital again and again. So if you can facilitate them using a model of telerehabilitation, that would be excellent. Apart from that, it has also been used in geriatric rehabilitation as well. It has also been used, as I just mentioned, in pressure ulcer management, follow-up, and prevention, both in spinal cord injury and in stroke. I gave you two examples of using telerehabilitation in disasters, and this is being commonly used in any natural disaster in any part of the world nowadays. Then physical therapy and other components of rehabilitation can also be delivered online in a virtual environment. I just told you, you can have an online one-to-one or group setting physical therapy session using telerehabilitation. Sorry. So it could be a tele-physical therapy, a tele-occupational therapy, a tele-psychology session, anything, and also integrative health. So this is a long list of diseases and disorders in rehabilitation which have been successfully managed using a tele-rehabilitation protocol. So food for thought for all of us. Now coming to the summary of the literature search that I did. So what I did was, I cannot summarize like 2000 articles in 10 minutes. So I'm only going to stick with randomized control trial and systematic reviews and meta-analysis. So this was a rapid overview of effectiveness of telerehabilitation in physical therapy. And the main the conclusion was that telerehabilitation in physical therapy could be comparable with an in-person rehabilitation, and it is definitely better than no rehabilitation for conditions such as osteoarthritis, low back pain, hip and knee replacement surgeries, multiple sclerosis, and it is also effective in context of cardiac and pulmonary rehabilitation. Coming to telerehabilitation for stroke survivors, a systematic review and meta-analysis of 15 studies demonstrated that first of all, it reduces the cost. We are going to talk about this later on. But yes, telerehabilitation, the biggest advantage is that it reduces the cost because there is no traveling involved for the patient and for the family. And telerehabilitation can be a suitable alternative to usual rehabilitation care in post-stroke patients, especially who are located in remote areas or underdeveloped area. It is very, very important for developing countries, because developing countries are not all equal. So there might be someone living hundreds of kilometers away from the main rehabilitation center. And for that person, it might not be possible to visit that rehabilitation professional. But if you give them an option to have a teleconsultation, it is actually save them a lot of time, hassle, energy, and money. And it's going to improve the overall rehabilitation services for that particular patient. Then telerehabilitation has also been used for chronic respiratory diseases. And this is a systematic review of 15 studies which used 5 different models of telerehabilitation. And the conclusion was that primary pulmonary rehabilitation, that is the first time rehabilitation, or maintenance rehabilitation, that is done in the long phase, which are delivered via telerehabilitation for people who are having chronic respiratory illnesses, it can achieve outcomes similar to those of traditional pulmonary rehabilitation, and there are no safety issues identified during tele-rehabilitation session. So it's not only safe, it is probably, if not more, as effective as in-person sessions. Then coming to telerehabilitation services for stroke, this systematic review analyzed 22 trials, and the summary was that studies comparing telerehabilitation and in-person therapy have not found significantly different outcome between groups, suggesting that telerehabilitation is not inferior. So yes, you can say that telerehabilitation is not superior to in-person consultation. That's fine, but then it is not inferior as well, which means it is almost as similar to in-person consultation in certain diseases. So whenever there is no rehabilitation available, the least we can provide is a tele-rehabilitation consultation. And there's a low to moderate level evidence that telerehabilitation is more effective or even similarly effective a way to providing rehabilitation services to patients with stroke. Then coming to again effectiveness of telerehabilitation and physical therapy. This was a question that can telerehabilitation be an effective alternative to conventional rehabilitation in physical therapy practice? 29 articles were explored, and the main conclusion was that telerehabilitation offers positive clinical results which are even comparable to conventional face-to-face rehabilitation approaches. Telerehabilitation has also been used in Parkinson's disease. It was a randomized controlled trial, multi-center, single-blind, in which 76 patients with Parkinson's disease were randomly assigned either to receive in-home virtual telerehabilitation, or they were asked to come to a clinic in which they were provided clinical sensory integration balance training, 21 sessions for 7 consecutive weeks. And the conclusion was that virtual reality telerehabilitation is a feasible alternative to in-clinic sensory integration balance training for reducing postural instability in patients with Parkinson's disease who have a caregiver at home. So at least in cases of developing countries, our patients do have caregivers at home. So if they cannot go to the hospital, the least you can do that, offer them a telerehabilitation consultation in which they are offered certain exercises, and they perform these exercises under the supervision of a physical therapist or a rehabilitation medicine professional virtually, and their caregiver or attendant is there to support and help them, and the outcome will be as good as a in-person session. Telerehabilitation has also been offered in total knee arthroplasty, again a meta-analysis of 4 RCTs, and the primary outcome was pain relief and WOMAC OA index improvement, and the result was that telerehabilitation should be recommended because of its comparable pain control and improvement of functional recovery. Telerehabilitation has also been used in musculoskeletal condition. Again, 13 studies, sorry, 13 studies, and the conclusion was that real-time telerehabilitation appears to be effective and comparable to conventional method of healthcare delivery for the improvement of physical function and pain in a variety of musculoskeletal condition. Post-stroke aphasia is a major issue, and there is always issue with access to speech and language therapist. I'm not sure about Indonesia, but at least in developing countries like Pakistan, we don't have many speech and language pathologists available. They are only concentrated in larger cities, and many patients with stroke who have aphasia are unable to go to them and get their services. So if you can offer telerehabilitation based speech therapy, it's going to improve the outcome. And this was the conclusion of this meta-analysis based on 5 studies, that telerehabilitation and face-to-face speech and language treatment are comparable. Both are almost similar and equal with respect to gains achieved in auditory comprehension, naming, generalization, and functional communication skill. And there is a low quality evidence that telerehabilitation seems to be as effective as a face-to-face session when it comes to speech therapy. Telerehabilitation was very successfully used recently in COVID-19 as well, and I thought it's a good idea to sort of describe that as well. So basically, what was the advantage of integrating telerehabilitation and remote rehabilitation during COVID-19 services? First of all, it promoted protected and early discharge for the patient. It ensured the continuity of care for the patient who were having COVID-19. It ensured patient care for patient without COVID-19, because many patients with disability who did not have COVID-19, sorry, I have a sore throat, were unable to get the services of rehabilitation professionals because of these problems. So in those patients in which telerehabilitation was offered, continuity of service was ensured. And the important thing was that different rehabilitation hospitals were actually connected in a hub and spoke kind of system, and they were able to share their complex clinical cases with other colleagues all around the country and all around the globe. And the most important maybe for a developing country was that it conserved the PPEs. Because if you don't touch the patient, if you don't go near the patient, this means you don't have to wear a PPE. So this means conservation of PPE as well. Now coming to the last part, advantages and challenges of telerehabilitation. So the biggest advantage of telerehabilitation is that first of all, it avoids travel to the clinical or medical center. And the consultation is actually done in the familiar home environment, which means a lot of emotional support for the patient. And this actually overall reduces the care of cost for the patient. And I'll give you an example of a traumatic spinal cord injury and stroke patient. So please imagine that a patient with cervical spine injury has to go to a rehabilitation professional for consultation. He or she is not going to go alone, at least in a developing country like Pakistan. This means at least 2 or 3 members will take time off from their duty, their work. They are going to hire a special ambulance for that patient. They are going to transport that patient. They are going to travel 1 to 2 hours to reach the main rehabilitation center. They are going to wait for the patient for their turn. And then when the patient is examined, they are going to go back. actually a whole day will be spent, a lot of finances will be spent in a single follow-up consultation of a spinal cord injury and a stroke patient. And just imagine if that consultation is being done in the familiar home environment, in which at one end a rehabilitation medicine professional is sitting, and on the other end the patient is comfortably sitting in the chair or in lying in the bed in his or her own house. The emotional support and the ease, right? Then there will be no waiting time, because usually tele-rehabilitation consultation are done at a specific predetermined period, which means that at that particular period, both the rehabilitation medicine professional and both the patient will be available. So there will not be a lot of waiting time. And it would be a very less stressful and easier process both for the patient, their caregivers, and for the professional as well. And there will be a lot of flexibility for the rehabilitation professional, because he or she does not have to be in his or her own clinic. They might be like on a medical conference, or they might be on leave, but still they can do a tele-rehabilitation consultation comfortably sitting in their own room. So there's a lot of flexibility for the rehabilitation professional as well. But at the same time, there are certain challenges that we need to understand and we need to address them. And the first is cost of technology. We need to understand that, it might look easier, but not everyone is able to afford a good smartphone. There are poor people out there. There are people who have spent all their resources on the management of acute disability, traumatic spinal cord injury, or stroke, or amputation. They don't have those kind of fancy, high quality, high end smartphones. So cost of technology is an issue. Then there is issue with internet connectivity and access. Not every part of the country is going to have a higher bandwidth. And you need to understand that a good tele-rehabilitation consultation is the one in which you can have a video conversation. Because if you can't see the patient, if you can't see your doctor or your rehabilitation professional, then it's a simple telephone call. There's no fun of like doing a tele-rehabilitation consultation. And a video takes a lot of bandwidth. It requires high-speed internet, which is not available to many people living in remote areas. So it's a major issue. Then not everyone is very comfortable in using technology, and the equipment might fail in between your consultation. It happens. It's technology. These are machines, these are tools. And many a times, at least patients who are old patient, who are less educated, they find it very difficult to navigate through these applications, most of them which are in English language. So if they are not in the local language, the patient or the caregiver are going to have very difficult issues while navigating through those applications. Then personally, this is the most important for me. There is a lack of healing touch and personalization. The patient at the end of the day, they want to be seen by their doctor or their rehabilitation physician. That healing touch in which you examine the patient, in which you see the patient, that kind of, like intimacy that develops between a physician and a person with disability, that is sometimes lacking in case of a tele-rehabilitation consultation. And the most important is there's a lack of clinical examination and assessment. I mean, how can you do an assessment of tenderness, range of motion online? It's almost impossible. How can you assess in detail that whether the patient is having contracture or not? It is not possible. So only a limited sort of examination can be done online virtually. Then they are concerned about data security, because most of these video and audio are actually stored in another third party server. So who's going to have access to my medical records? It's a major concern. And sometimes these medical applications, they don't give you an answer. And last but not the least, there are no like standardized guidelines and protocol for different countries. So how should I do a tele-rehabilitation consultation? Is there a specific protocol that need to follow? So at least these protocols are not existing in developing countries. And I assume this is the same case for Indonesia as well. So the summary is that telerehabilitation is evolving. It's a fantastic piece of technology which holds a lot of promise in future for rehabilitation medicine delivery services. At present, now it is widely available because of increase in communication tools and access to internet. And it can actually reduce the cost of care and provide easy access to rehabilitation medicine physician in any part of the world. But at the same time, there is a need to address the challenges which have been identified, like poor internet connectivity, lack of personalization, reduced assessment of the patient. And therefore, it is important for a rehabilitation medicine doctor to get familiar and comfortable with this piece of technology and tools of rehabilitation which are rapidly coming up, because change is inevitable and growth is optional. And COVID-19 recently told us clearly that we have to be adaptable and we have to change as per the changing norms of the world. And intelligence is the ability to adapt to change. I thank you all If there are any questions, I'll be glad to answer them. And I thank you again in the end for inviting me here. Stay blessed. Assalamu alaikum.